Good morning and welcome. I'm Mohammad Jaafar from Washington, D.C., and on behalf of APOS, I would like to thank the organizing committee and the president of the SOE 2019, president of the European Society of Ophthalmology for the invitation, and welcome to the first session on strabismus. I just realized this morning that the session co-sponsored by APOS was all female colleagues, and our strabismus session is all going to be all male, so we'll see who's going to do better. The first session was excellent. I have no conflict of interest to declare. I'm talking about reoperations in patients whom we thought were uniocular superior oblique palsy. We are all aware, we have learned in residency and fellowships how to diagnose superior oblique palsy, which is bilateral. We use the 3 steps test of Parks, the double Maddox rod, and look for X-cyclotorsion, both objective and subjective. This is a typical presentation of bilateral superior oblique palsy. We have a V pattern, strabismus, right hypertropia and left gaze, a left hypertropia and right gaze. The Bilshofsky head tilt test is positive to both sides. That tilting to the right, we have a right hypertropia. Tilting to the left, we have a left hypertropia. And the double Maddox rod is usually positive. And we've learned that if it is more than 10 degrees, we should be suspicious of a bilateral palsy. So this is the classical superior oblique palsy. We also have learned that there is a manifest bilateral superior oblique palsy and a masked one. We've learned that the traumatic superior oblique palsy are bilateral until proven otherwise. So based on all these things, my colleagues and I thought that we know how to diagnose bilateral superior oblique palsy and ended up with some who are purely superior, unilateral. 30 years ago, Bert Kushner came up with his very classical paper where he talked about bilateral superior oblique palsy, masked and almost masked and super duper masked and the whole thing. And in his paper, he remarked that these patients have a chin down posture, possibly a small head turn, or no abnormal head posture altogether. Their hypertropia in primary position is usually small. They have bilateral X-cyclotorsion that can be seen objectively by fundoscopy or subjectively by double Maddox rod. And also, and most importantly, these patients, if you study them in the non-cardinal positions of gaze, they have right hypertropia everywhere except in one gaze, which is a left hypertropia. So it was very important for him to study those patients' non-cardinal position of gaze measurements and assessing the fields of oblique fields. His patient's population was 16 to 57 years of age. So it is an adult patient population, a little bit on the older side. And this is a typical presentation. This is from his paper, case 1. Patient has a right hypertropia everywhere except in up and right gaze, where the hypertropia becomes a left hypertropia. In case 2, everything is right hyper except down and to the right, to a small left hypertropia. And in case 3, everything is a left hypertropia except up and to the left, which becomes a flick right hypertropia. And if you look at the X-cyclotorsions, 8 degrees, 5 degrees, 8, 0 and 7, but by fundus examination, 2 out of 3 where he looked, they were bilateral. The third one, it is not reported, not tested. Again, this is an adult patient population. He remarked, as others, like Scott and Kraft, Ellis and Guyton, and that in superior oblique palsy, the difference in the hypertropia between right and left tilt is much smaller than when we have a unilateral superior oblique palsy. Again, we know that. He reviewed 112 cases, 90 were unilateral and stayed unilateral, 4 were masked, and 5 were almost masked, meaning that he caught them before he finally did the surgery. And 13 were bilateral. So he had 99 patients that were thought originally that they were unilateral cases. And he did multiple procedures. He did recession of the inferior oblique, tucked the superior oblique or did vertical rectus surgery. Now, our experience in Washington, D.C., we had 102 cases that I thought, and my colleague thought were unilateral cases. 73 out of the 102 remained unilateral. 29 became unilateral or had some abnormality on the other side. The mean age at onset was essentially the same, 9 years in all these, but the median age at diagnosis was a little bit younger in the masked bilateral superior oblique. Is it because of the bilaterality that the diagnosis was a little bit early, or was it that we missed these patients because they were much younger? We don't know. As Kushner and others have described, the patients who turned out to be bilateral had a much higher rate of bilateral excitrotorsion, around 14% versus 13% in those who stayed unilateral. The abnormal head posture in true bilateral patients, and these are aside from the 110 cases, we had 67% of these patients had a straight head posture, no chin down, no head turn, no head tilt, nothing. In the unilaterals, it was 8%. In the masked bilateral, it was 21%. So again, there were hints in retrospective analysis, and this is another findings. The median hypertropia in different gazes. In primary position, the deviation in primary patients was around 11 prism diopters, and it was less. It was around 4 to 5 prism diopters in the masked bilateral. And in the contralateral gaze, the median hypertropia, when you do the head tilt test to the contralateral shoulder, patients' right hypertropia, which with a right head tilt, will decrease from 10 or 11 to 3. With the mask, it starts smaller and essentially is neutralized on the contralateral head tilt. It didn't really matter if these patients had inferior oblique recession or inferior oblique myectomy. It wasn't statistically different. Both procedures ended up showing us the contralateral abnormality as time went. Surprisingly, the greatest majority of patients who turned out to be bilateral were congenital and not the traumatic ones. 10 years after Kushner, the Guyton group at Hopkins, Jim Ellis and David Guyton, studied their own patients, and they had 108, 72% of them remained unilateral. 27% as time went had some abnormality on the contralateral eye. And they really didn't know what was going on. So they compared both groups, and there wasn't any much difference in age of surgery, etiology, traumatic versus congenital, average hyperdeviation in primary gaze, ipsilateral and contralateral gazes, ipsilateral and contralateral head tilts, average V pattern, inferior and superior oblique muscle function or dysfunction, X-cyclotorsion, double Maddox rod, or X-cyclotorsion on fundus examination. So they really compared those two, and statistically nothing really came up. Again, in their series, as in ours, the majority of those masks were congenital and not traumatic. The median time interval between surgery on the first eye and when the abnormality started on the other eye was 2 months. The range was larger, 6.7 months, and went anywhere between 15 days and 5 years. Excuse me. 83% occurred in the first 4 months, and there were 3 patients who presented late, 14, 53, and 61 months. But the greatest majority were before 4 months after surgery on the first eye, and the mean was 2 months. 10 patients, or 9.3%, had 1 or more Kushner proposed signs of bilateral superior oblique paresis before surgery, but only 2 of those 10 ultimately developed contralateral pathology. So even if, prospectively or retrospectively, we look at those patients, the Kushner's criteria really did not help very much. This is a scheme, modified from their presentation. This is a patient with right superior oblique palsy, right hypertropia in primary position. The hypertropia increases with the right head tilt and decreases or disappears with the left head tilt. And we can see in here an overaction of the right inferior oblique on left gaze. So typical case of right superior oblique paresis. Postoperatively, be it a recession of the inferior oblique or a myectomy, the patients developed a right hypotropia. But if we ask the patient to fix now with the previously paretic right eye, same measurements, okay, same patient, we move from a right hypotropia to a left hypertropia. So let me make this a little bit larger. This is what we have in here. So now the patient is showing a left hypertropia. In right gaze, the patient does not have any hypertropia because the weak superior oblique muscle here is not strong enough to keep pulling the eye down and creating more right hypotropia. And in here, this left hypertropia that exists with a left head tilt, the right superior oblique has nothing to do, and we see left hypertropia on left tilt and no hypertropia on right tilt. The point that is made in here, in right gaze, the patient has a left hypertropia, a little bit increased from what we have in primary position, and in left gaze, the hypertropia goes away. So Guyton and Ellis think that this is really an overcorrection of the right superior oblique surgery. And this is why we have now a right hypotropia instead of a left hypertropia. And this is what's going on. Again, preoperatively, right hypertropia increasing with the right tilt, increasing in left gaze. And postoperatively, this is an overcorrection, and the patient went from a right hypertropia to a left hypertropia or a right hypotropia. And what we had on head tilt, et cetera, follows the fact that this is an overcorrection and not a missed contralateral superior oblique. And this is their conclusion. Surgical overcorrection of a unilateral superior oblique muscle paresis can masquerade as an apparent contralateral superior oblique paresis. This is caused by a persistence of the head tilt and side gaze misalignment pattern from the original superior oblique muscle paresis. So it is not a missed contralateral superior oblique palsy, it is an overcorrection of the first thing. So this is a summary of the three series. Kushner found 9% of patients who were masked. Guyton and ourselves found 28%. The onset of the contralateral pathology is early, in weeks, couple of months at most. Very rarely it is delayed. It's equally seen after myectomy or inferior oblique recession, and it is, for whatever reason, more common in congenital cases than traumatic cases. Merci. Now, and with no further ado, I'm going to introduce Dr. David Nash from La Crosse, Wisconsin, who is going to talk about overcorrections after unilateral fourth cranial nerve palsy. David?
Thank you very much. It's a pleasure to be here. I've never been to Nice, so this has been wonderful and gorgeous. So yeah, I come from La Crosse, Wisconsin. I have nothing to disclose, it's a smaller town, so I thought I'd share where it is. It's sort of middle of the United States and all the way up next to Minnesota. But we're along the Mississippi River. We've got the beautiful bluffs. It's a pretty rural area, a small community. The coverage area of our health system is about 400,000 people, but the town itself of La Crosse is around 60 to 70,000, and I work at Gunderson Health System in the ophthalmology department there, practicing pediatric ophthalmology and adult strabismus. So I like fourth nerve palsies. I think they're fun. I think that you have a great opportunity with these types of patients to make them happy. They come in, whether it's correcting a head tilt, a torticollis, or or collapsing and incompetence or resolving double vision, getting them out of prism. These patients can be very grateful. And I think when you find that right surgical combination for their deviation, they tend to do really well and they love you for it. So these can be very fun surgeries and fun patients, but of course it doesn't always go that way. So, and we can, just as we sort of come off of our listening to Dr. Jaafar, we'll go with a case here. So this is a middle-aged male, long-standing intermittent double vision that's been corrected with prism, but has been getting worse, has a left hypotropia or a right hypertropia, as we can see here in this picture. Some facial asymmetry, they notice a diagonal double vision, but they don't notice any twisting of the second image. So some of those things argue for this is a long-standing, likely congenital process. And we notice there's right inferior oblique overaction over here. And when in right gaze, there may be a little bit of limitation of depression with that right eye, suggesting a possible superior rectus contracture. Measurements sort of kind of are consistent with that, but we're thinking this is a right superior oblique palsy, sort of a moderate deviation, really not that incompetent, but again, we were sort of looking at maybe that right superior rectus is a little bit tight, and we can see where that down and right gaze is about 20 prism diopters. Again, sort of has us sort of wondering a little bit about that, and this is, we start thinking about our surgical planning and how are we going to help this patient. This is where we start wondering, you know, are we going to just weaken that inferior oblique, or is there something else we need to do near their deviation? 16 prism diopters. They had 3 degrees of cyclotorsion. So forced duction showed a tight right superior rectus. No evidence of a Brown syndrome. So the superior rectus was tight, so the decision was to recess that on an adjustable suture. But again, with 20 prism diopters deviation, we thought, well, just in case, let's also look at the contralateral left inferior rectus and recess this as well. Postoperatively, the patient was left with 8 prism diopters of undercorrection. This was felt to be too large, so we further recessed those vertical recti, and this left us with the 2 prism diopters of right undercorrection. So I think this looks like a good result, and not unreasonable, and a good place to stop. But of course, we're talking about overcorrections, so we kind of know where this is going to go. And by 3 weeks, the patient's very unhappy. They got 6 prism diopters of overcorrection, left hypertropia, actually worse than left gaze here. So this wasn't thought to be a unmasked bilateral, but they're quite unhappy. So what happened? This is a common situation. I mean, we see this. It's not common, but we do see it. And these patients, I think, often stick in our mind. We know we build our own hopes up, and sometimes we maybe even build the patient's hopes up that we're going to get you out of your prism. This is a great surgery. We're going to really help you here. And then a month, a year, thereafter, they say, what happened? This is awful. You start getting the phone calls in your office. So we know that in these single muscle group, or these small deviations, less than 10, 15 prism diopters, it seems pretty straightforward. One muscle seems reasonable. I wouldn't do 2 muscles for a 10 prism diopter or a 6 prism diopter deviation, assuming we're just talking about verticals here. And large deviations, when we get above 30 prism diopters, or some people say 20 prism diopters, or wherever your cutoff is, or however you were taught, 2 muscles seems, again, not unreasonable. But it's that medium deviation, that 15 to 25 prism diopters, where we start to say 1 or 2, is 1 enough? And I think the opinions differ, and case reports, again, are showing our different practice patterns. Even very recently, just this last year, there's been several different fourth nerve palsy papers that have come out. Akbari et al. Here just published a case series of 39 patients having these moderate angle deviations, but ranging from anywhere down to 3 prism diopters in primary gaze all the way up to 30, all treated with unilateral myectomy. And they did very well. No overcorrections at all. But they did have some undercorrections, and those patients were symptomatic. So that's the one approach with those moderate angle deviations, this single muscle approach. More like our patient, where we have some superior rectus contracture, then, again, another recent publication looking at 15 patients with that same type of pattern, Moderate angle deviations, 23 prism diopters in primary, ranging 16 to 35, treated with the superior rectus recession. In this case, they, on the same eye, weaken the inferior oblique, which I always sort of worry about weakening two elevators on the same eye, but no undercorrections, but 3 overcorrections out of the 15, all whom needed further intervention. So approaches differ. Our patients are different. They don't all respond the same. So what's the difference between 1 and 2 muscle surgeries for these moderate angle deviations? How are they different? I think that's the first question we ask before, what's better? So during my fellowship, we published a report in 2017 looking at these two groups, looking at unilateral fourth nerve palsies measuring 15 to 25 prism diopters, all of whom had presumed unilateral fourth nerve palsies. None of these patients had simultaneous horizontal muscle surgery correction. All patients were above 5 years of age so that they could exhibit, or in hopes that they would be able to adequately speak to either torsion or double vision afterward. No things like Graves' disease and purely torsional surgeries were excluded from this, so things like carotid. So in this group, we had 45 patients with 2 muscle surgery, 28 with 1 muscle surgeries. The most common 2 muscle surgery was a ipsilateral inferior oblique weakening with a contralateral inferior oblique recession or weakening, and the most common 1 muscle surgery was inferior oblique surgery. At 6 weeks, when we look at motor success, which was defined at 4 prism diopters or less of undercorrection with no overcorrection at all, or diplopia success, which would be never or only rare double vision in distance or near gaze, they were actually about the same in terms of success. The deviations were, the medium deviation for the 1 muscle surgeries were closer to about 16 versus 19 in the 2 muscle surgeries. So the groups maybe were a little bit different. But as one would sort of think, the 1 muscle surgery group had more undercorrections. The only overcorrections occurred in the 2 muscle surgery group. And every overcorrected patient had diplopia or was a diplopia failure. So they are unhappy. Only 40% of the undercorrected patients were symptomatic and required further either prism or surgical intervention. So where does that leave us? We know overcorrected patients are unhappy, but I think everybody sort of expected that, and we fear the unmasked bilateral, we fear the overcorrection. I think the next step is not just, well, do 1 muscle for everything, because there isn't a one-size-fit-all for every patient. Patients are different. There are probably situations in which 2 muscle surgery is appropriate. So are there any clues to overcorrection? And I think that's sort of where the next step of things should start to look. So we did go back and look at those 45 patients with 2 muscle surgery to just see if there was anything preoperatively that may have been associated with an overcorrection. These are the surgeries in that 2 muscle group. Again, the most common being the inferior oblique weakening with the contralateral inferior rectus weakening. Some of the patients did have superior oblique surgery here. However, these were not Hirata-Ito surgeries. So what we found in this group is that smaller ipsilateral gaze deviations preoperatively were more likely to be associated with overcorrections, the medians of 8.5 versus 16. And so then using a statistical technique called cut point analysis, which takes a dichotomous outcome, in this case overcorrection or undercorrection, applying it to a contiguous group of variables or prism diopters of deviation, you can find the split where the group's different. And the ipsilateral gaze of around 9 prism diopters in this group seemed to be the cut. So patients with 9 prism diopters or less in this group in ipsilateral gaze were associated with overcorrection and 2 muscle surgery. And then, as one would expect, greater degrees of lateral accommodance trended towards overcorrection. Looking at preoperative torsion, which wasn't available in every patient, about 36 of the 45, it seemed like less preoperative torsion may have been associated with overcorrection. So if we go back and think of that case presentation, actually none of this really applies, because there again, and we're proving the point that there are always exceptions. They did seem to have less preoperative torsion, but I don't know if we can necessarily hang our hat on that. But so what do we know? We know that overcorrected patients are unhappy. And there, I think that leaves us sort of in two places. If I know for me, looking at this data and other recent reports, I lean towards one muscle surgery for more of my patients, and I'm not just cutting off at 15 or 20 prism diopters, but if I'm going to do a two muscle surgery, I want to be absolutely certain that I've looked at everything possible. Of course, knowing that I can easily miss things, but this is sort of given me pause to at least look at inferior, or looking at the ipsilateral gaze, looking at incompetence and torsion. If I see a very small ipsilateral gaze deviation, again, that's pushing me more towards one muscle surgery. I think that this is something that could be easily replicated with, especially looking at things like big data that we are starting to have more available to us. But I think the other key component in these patients is setting appropriate expectations, letting them know that there is a chance for overcorrection no matter what we do, but we're there walking with them the entire way. All right, thank you very much.
Thank you, Dr. Nash. Now it's my pleasure to introduce Dr. Faruk Örge from Cleveland. Dr. Örge is the Althans Professor and Director of Pediatric Ophthalmology and Adult Strabismus. He is at Rainbow's Children's Hospital, Professor of Ophthalmology at Case Western Reserve. Faruk is the Vice President of IPOSC, and he is Director at Large of APOS. Dr. Örge.
Thank you, Dr. Jaafar. It's really a great pleasure and honor to be here and be able to speak in front of you. I'm going to talk about iatrogenic strabismus, and we're going to tag team with Dr. Christiansen a little bit. He's going to talk about the hardware and cause and talk about what to do in those cases. I'm not going to touch base on what to do in general. I'm going to give you maybe some examples, but just to go through, and with a very short period of time, there's so much to talk and little time, so we'll go through that one at a time. One source I wanted to plug in is if you haven't been into the Pediatric Ophthalmology Education Center, which is an online source open for everybody and anybody that has been built with the partnership of American Academy of Ophthalmology and the APOS. Please feel free to go there, and it's been gaining traffic, but it's a wealth of knowledge, and it's been increasing every year, just to give you an insight. Iatrogenic strabismus comes in many shapes and forms and caused by many different types of surgeries. So I wanted to start with the non-ophthalmic surgeon. So it's not only because of what we eye surgeons do, but obviously neurosurgeons and ENT surgeons can cause the iatrogenic strabismus. We're going to talk about that a little bit. Also the ophthalmic surgeons, obviously retina, cataract, glaucoma, oculoplastics-related iatrogenic strabismus happens frequent enough. But then there's a strabismus surgeon-related iatrogenic strabismus, which is an own category, I think, on its own, and we're going to talk about a little bit about that as well. The neurosurgeons, obviously, for sometimes obvious reasons, sometimes not, sometimes as well, they know they're cutting into certain nerves. So this is a child with a third nerve palsy. In particular, the brain surgeon did know that they had to remove the tumor and they were cutting into the nerve and they had nothing to do against it, so they had to do it. Some of them are just known, some of them happens without their knowledge. And sixth nerve palsy, obviously, this is a fourth nerve palsy, and Dr. Jaafar was talking about the chin down gaze for the bilateral fourth nerve. So it does happen, again, comes in different shapes and forms. But in general, these are cranial nerve paralysis type of problems. ENT surgeons do bring us business quite a bit. I think these are probably some of the worst case scenarios in certain instances, and you can see that this young lady actually received a uncomplicated sinus surgery, woke up, everything went well, but she said, I see double. And you can see the little exotropia in the right eye. And further, if you happen to have her look to the right and the left, there's this little restriction in the left gaze, and these are the other gazes here too. We later on learned that the ENT surgeon, and I don't know how many people have seen the surgery or the machines that they use for the sinus surgery. It's a very powerful tool. It has a rotor and go through a very thin piece of a bone very, very quickly, and they don't even know about it. So in this case, they actually happened to go through the medial wall and destroy the medial rectus. And in these cases, you can't piece them together. At least in the few that I have seen, I never could be able to find anything to put together, and these are very bad cases. What to do for these cases? I remember listening to a talk from Dr. Kraft from Toronto, Canada, that it was mentioning that in his series, he actually said, as soon as I do these traction sutures, as you're seeing there, it actually at least keeps them in a gaze. The problem with these cases are these are not typical muscle injuries, and you have a lot of inflammation in the scar tissue, and they tend to freeze in a position. So just a tip, and remembering how he did that, we did the same thing in our case. Obviously, there are a lot of ways to fix this, but if you're going to do this type of traction suture, I would advise you to do this early on in the first few days, even if you can get to it. Retina surgeries can cause problems due to materials, scleral buckle and sponge. Again, Dr. Christiansen is going to talk about them. The scar tissue and actually muscle injury is a very, very common thing. It used to be more common, especially when the scleral buckle was the only technique that was available many decades ago. Now the vitrectomies and the anatomical know-how is very different. So we don't see as much, but we've seen also orbital fat adherence, and it can come with vertical, horizontal, torsional combined, or even as a fixed globe. So an example of a case that actually had a 30 prism diopters of left intermittent hypertropia. It really looked like a DVD, but when we went in there, there was a vague history of a trauma in the childhood. We saw the sponge, and we removed it, and we did actually recess the muscle, and with good outcome. So always think about what can happen, and sometimes the patients are not the best historians, especially if things happened 30, 40 years ago. Another case, this is actually another scleral buckle. I'm not going to go too much into it, but as you can see, the whole complex, that's the buckle itself, the complex of the muscles, could be all adhered in these cases. You need to really clear everything out. Glaucoma surgeries can cause many problems, mainly restrictive. Tube shunts can cause this, scar tissue can cause this, muscle injury obviously can happen, and orbital fat adherence. I think those, again, when you hear the fat adherence, I think those are the toughest cases. Sometimes you just don't have much to do and to help them. Again, comes in different shapes and forms. Just a few examples. This is a young lady that received a tube shunt, and you can see in the right eye is higher, the left eye has a difficulty looking up, and it's to do with this big shunt and the bleb that was caused to that. Another example is actually, again, a tube shunt, but this is a different pathology. You can see this is fairly opaque, but this is translucent. This is a cystic bleb that causes a mass effect more than a scar tissue, but this is a more involved scar tissue that is incorporating the lateral rectus as well as the superior rectus and superior oblique complex. So cases can come in different formats too. Well, not only the tube shunts, the trabeculectomies can cause problems too, and so this patient actually had a right hyper after a uneventful glaucoma surgery, and another gentleman actually had restriction again in the adduction after a trabeculectomy. So it can come in different forms and shapes. If you're going into surgery, and Dr. Christiansen probably is going to mention these things anyhow, you need to either go with a glaucoma surgeon, or you need to have good experience on glaucoma surgeries, because you may want to or need to undo what was done. Obviously, oculoplastics, because of the trauma and all the materials that they use, and we have patients that are coming from Cuba that they do these fat injections and many other things that actually misplace the globe and causes many scar tissues as well. Again, and scar tissue, muscle injury, orbital fat adherence, all these things still apply. And it could be as relatively simple. It's not simple, but relatively simple, like this case, that actually this patient had a melanoma, and the orbital surgeon had to put a plate to for the treatment of the melanoma itself. And you can see this is a marker. They put a little ring to kind of show the location. And uneventful surgery but caused a lot of scar tissue right in that region. The blood in general gives you an indication how scar tissue was there. But one step up would be a patient like this actually, and you can see that the left eye is moving freely, the right eye is just stuck, and even you can see the lid complex is fairly stuck in this rim. So this patient had multiple orbital surgeries that the lid, the inferior oblique, the inferior rectus, conjunctiva, anything that you think in that region is all fused together. These are obviously very different cases compared to the one that I just showed you previously. But let's talk about the strabismus surgeons, us causing problems too. We're not immune from that. We do know the anatomy. We talked about overcorrections and other corrections, and even with the best intentions in the hands of the best surgeons, we do have, again, problems that we see, and all the things that you've seen caused by other surgeons, we can cause that too. A few examples. This is a 25-year-old female that actually received a R&R surgery and otherwise healthy, and was just realized a vertical diplopia. And when we went in to explore the area, this is the lateral rectus on the right eye, you can see this little hump there. Actually, I don't know how that was, but I've seen this often enough that the inferior oblique was brought next to the lateral rectus, and you can see this. We identified that. What we did is actually marectomize it, clean the entire tissue, and that's all we needed to do, and got rid of the hyper as well as the minor horizontal problem that she was having. If you ever see a non-existent prior to the surgery vertical deviation on an R&R in particular, or re-op in the lateral rectus, think about an inferior oblique inclusion syndrome. These are not uncommon, actually, was defined before. Obviously, slip muscles and elongated scars and hangbacks sometimes act like these elongated scars. You can see that this hook is underneath this so-called muscle, but you can see the entire hook. This is very different, and the muscle is all the way here. There is a scar tissue in between and more transparent elongated scar tissue way beyond that, and this patient looked like a lost muscle by all means. Sometimes you think it's a lost muscle and you can find these adhesions. This is such a patient that way deep, if you're lucky enough, you can actually find a rectus muscle and even salvage that. Very, very difficult. Another thing that may happen, I hope it never happens to you, but if you've done this enough, I think it's, you will see it nonetheless. And this is a patient that I was doing with my fellow, and the fellow is an excellent surgeon. All of a sudden, I turned my eyes away from the patient. I heard a oops, and the entire thing was kind of, the area was full of blood. The inferior rectus was pulled in two. What you do is, first of all, don't panic, take a deep breath, try to control the bleeding. The one trick that I learned with the inferior rectus trauma is, and Dr. Baker actually pointed out, he knew this, I happened to kind of learn it on the way. If you push on the globe, then all of a sudden the more deeper portion of the muscle that was broken, because it's still adhered to the inferior oblique and the retractor, lower lid retractors, it tends to peek out. And all of a sudden you can see that little edge of the muscle and hold on to it and tie them together. And that's exactly what we did. And in this case, you found this muscle, you tie them together. I actually used 6-0 Vicryl. I do use 3 sutures, and they do fine. And we had transposed the muscle because this was actually also a lost muscle. Poor lady went through many problems, and this is post-op day 4 and post-op day 7. She did fine. In summary, as Dr. Helveston had said, and I always quote him for this, better do a good surgery for the wrong indication than a bad surgery for the right indication. So a clean surgery is much easier to reverse. Make sure that you pay attention to the anatomy, go one step at a time, no rush. The expectation of the patient has to be in the core of the discussions and surgical planning for these particular cases. Some of them are extremely complex. They may need multiple surgeries. They need to know this in advance. And even with the basic surgeries, as you can see, we were not planning on a pulled-in-two syndrome. It can happen. Just discuss that things can go wrong. But when things go wrong, keep your calm when bad things happen, and communicate with the patient with complications when complications occur. And again, good luck. I think we all need that beyond anything else, and thank you. And I'm just going to stop right there. Thank you.
Thank you, Dr. Örge. As you've noticed, we're not taking questions after the talk, but we'll have plenty of time at the end to answer your questions. So please write them down, and we will have time at the end of the session. I would like to introduce Dr. Steve Christiansen, who is the professor and chairman of ophthalmology at Boston University in Boston, Massachusetts. Steve.
Thank you, Mohamad. Thank you, audience, for your attention, and thank you to the organizers of this meeting for allowing me to speak this morning. Thank you also to Faruk for doing such a wonderful job of introducing my talk. I have no relevant financial disclosures, although I am a consultant for AbbVie. I'm going to drill down on two of the areas that Faruk spoke about, and that is patients who have strabismus after placement of a scleral buckle and patients who have strabismus after placement of a seton. As we all know, there are many potential causes for strabismus after placement of a scleral buckle. One may be just sensory deficit strabismus. I mean, patients who have retinal detachments often have poor final visual outcomes, and many of these patients will end up with sensory exos or ESOs or other forms of misalignment. But patients with superior oblique incarceration will also present with vertical deficits. Extraocular muscles may be injured during the placement of the scleral buckle. There may be anesthetic myotoxicity that complicates the story. These patients, especially if the tenons has been violated and orbital fat advances, can have orbital fat adherence. There can be a Faden effect where the extraocular muscle actually sticks down to the scleral buckle, or even worse, posterior to the scleral buckle, and you get a reduction of its mechanical vector. There can be misdirection of these muscle force vectors by the scleral buckle. There also can be mass effects of the hardware, including the encircling element and other things. And then clearly there's a combination of the above. I thought it'd be interesting to just present a case that came my way when I was in Minnesota. This was a 45-year-old woman who had 20 years ago had bilateral scleral buckle placement for retinal detachments related to her high myopia. And what she had noticed over the past year and a half to 2 years was gradually worsening right exotropia, limited motility, and significant diplopia. She also complained that her eyes hurt. And that's not an uncommon finding after placement of a high scleral buckle. Here she is in primary gaze again, here she is in right gaze, here she is in left gaze, here she is in up gaze, and clearly both globes are almost completely frozen. So this is a case where the scleral buckles appear to be a problem, and just wanted to discuss briefly when to remove the buckle. In some patients, it's very evident the buckle is the cause, as this patient represents, and the scleral buckle needs to be removed. And we often worry about the risk of removing the scleral buckle, but in fact, the risk is relatively low, 0 to 8% redetachment rate following removal of scleral buckle. So it's prudent in my mind to always consult with the retina service about their buckle before you remove it, and most of the time the retina surgeons will agree that it's reasonable to take it off. But it's important to remember that redetachment can happen after scleral buckle removal, and it's more common if the interval between the placement of the scleral buckle and the removal of the scleral buckle is relatively short. In addition, if PVR is present, or if you have an uncomplicated or unstable retinal detachment, these patients are at higher risk for redetachment of their retina. And a case in point would be the patient who has a scleral buckle for a giant retinal tear and has PVR. So those patients are ones you'd be a little less enthusiastic about removing the scleral buckle. Lambert and co-authors reported in 2013 that their realignment rate after scleral buckle removal was dramatically better than if the scleral buckle was left in place. Other authors have not shown that significant a difference. Here's a scleral buckle from a screen capture of a video that shows the placement of the buckle. And if you can see my cursor here, you can see that these retaining sutures are a problem if you're thinking about removing the buckle, because they do hold the buckle in place and sometimes make removal difficult. So be prepared for complications during the time of your buckle removal. Here's our patient again, and you can see as we pull the lids back that there's something back there that just doesn't look right. And because of that, and because she had bilateral findings, I told her I really wasn't sure what we were dealing with, and we would do one eye at a time, and I'm very thankful we did. So here's what we found. And those of you who are familiar with scleral buckles from the 1980s will remember the bad old days of hydrogel. This was a hydrogel buckle, and these things hydrate over time and gradually expand and move forward. What we found at the time of our dissection, and I did a 360-degree peritomy, was that all of the extraocular muscle insertions look completely avascular, which was quite interesting. So the buckle was removed, and I didn't do any strabismus surgery on this patient at the time, just removed the buckle, because I wasn't sure what the mass effect of the buckle was. Well, post-op day 1, she came in complaining of significant eye pain, and I took her to the slit lamp, and she had Descemet's folds. She had a very inflamed anterior chamber, and clearly a case of anterior segment ischemia. We started her on both oral and topical steroids, and fortunately she resolved quite quickly without any visual consequences. 6 weeks later, I took her back. We did the other eye, took her buckle out, and then did an R&R for the Esotropia. And 3 months later, she came back with good vision in both eyes, remarkably improved alignment and motility with good stereopsis. So a success. But there are certainly patients where you cannot remove the scleral buckle, and in these cases, we'll often do recessions of tight extraocular muscles after removing the adhesions, and you place the insertion of the muscle that you're wanting to recess right over the old buckle. And so that can be a concern because we really don't know about the stability of adhesion of the muscle to the capsule or to the buckle itself. So some options include doing a hangback operation with non-absorbable sutures. You can sew it down directly to the capsule. I do this actually quite frequently, or you can sew it down to the buckle if you want to. Just make sure it's well documented in your operative report. You can do a recess resect of a single muscle and sew the muscle immediately behind the scleral buckle, or you can do what Lambert has described as a segmental buckle removal, where you retain some of the buckling effect and yet are able to attach your extraocular muscle to the sclera. The problem in my mind about this is that if you try to attach the muscle to where the buckle was, the sclera underneath is very, very thin, and so you've got to be extremely careful about placement of your sutures. So my recommendations, and this is your take-home message for this portion, is for patients who have strabismus after scleral buckle placement. Keep in mind that the diplopia and strabismus will often resolve in the first few weeks after placement of the scleral buckle. So it's wise to take some time and let the patient resolve if they're going to. Second, because torsion is such a significant problem in many of these patients, always check for torsion preoperatively. An assessment, either your own assessment if you're comfortable, or the assessment of one of your retina colleagues of the retina preoperatively is very important. If the retina is stable, remove the buckle, especially if you think the buckle is causing the strabismus. If you can't remove the scleral buckle, then you can do whatever modification you want to for your surgery to accomplish whatever the challenges are in the field. And it's important in these patients to always be careful to lyse as many of the adhesions as you possibly can, because removal of those kinds of restrictions are going to be your key to success. So how about strabismus after tube shunts? I'm going to present a case here of a patient I took care of. This was a 67-year-old woman who was referred to me in Boston from Connecticut. She had developed a left exotropia and constant horizontal diplopia 2 to 3 months after she had placement of a Beervelt in her superior temporal quadrant. For end-stage glaucoma, her vision was very poor in the left eye, but still excellent in the right eye. But despite the very poor vision, she still had constant diplopia. She had a horizontally concomitant exotropia that was worse at near. That doesn't seem too surprising, considering the fact that she had a -2 AD duction deficit of the eye with the Beervelt. And forced ductions performed both in the clinic and in the operating room showed that she had significant restriction to AD duction of her left eye. Examination of the ocular surface showed that she had a large cystic bleb in the superior temporal quadrant that extended inferiorly into the interpalpebral fissure and clearly was overlying the lateral rectus muscle. So we'll get back to her and just what kinds of things happen after placement of a Beervelt or another kind of tube shunt. Well, you can get a mass effect of the implant itself or of the bleb on the adjacent extraocular muscles. The extraocular muscle, as with the scleral buckles, may be injured during implantation. There may be extraocular muscle fibrosis of the extraocular muscle, similar to what we saw with the retinal detachment surgery, the Faden effect, and placement of a implant, a glaucoma drainage device in the superior nasal quadrant is especially problematic because these patients can have entrapment of the superior oblique muscle and development of a pseudo-Brown syndrome. Well, here's an exaggerated case of what I'm talking about. Here's a large cystic bleb of a patient who had a superior temporal quadrant implant, and this huge cystic bleb has created this restrictive, almost paretic restrictive esotropia in this very unfortunate patient. How often does this happen? Well, it's actually not that common. The TVT study, the tube versus trabeculectomy study, showed that the incidence of new or worsened strabismus after a tube shunt was about 10%, and after a trabeculectomy, 0% within one year of surgery. The older age and right eye surgery seem to be attributed to a greater risk for new strabismus and diplopia. The Mayo group, authored by Sun et al., showed that binocular diplopia is actually much more common, and their criteria for diplopia was a little more strict, and so I would probably trust this data a little bit better. But the risk here is low to moderate after placement of a tube shunt. And we have to think about what is contributing to this. And I just want to bring your attention to the fact that implant size makes a difference. Now, why do glaucoma surgeons implant big implants? It's because the larger the surface area of the implant, the greater their filtration area. And so for patients who are high risk or end-stage glaucoma, they'll often have large implants placed. These larger tube shunts, unfortunately, have larger filtering blebs, and these large filtering blebs can be risk factors for motility disturbance. And just to give you an example, here's a figure taken from the Academy website that shows a number of these different implants. Here's a single plate Maltino, a double plate Maltino, an Ahmed, and a 350 millimeter Behrvelt. And just to show you that 350 Behrvelt, you can see how large it is compared to the eye itself. These are massive devices that you're placing in the orbit. And this is a table from the Academy also that shows the various sizes of the implants themselves. Their surface areas are quite large, particularly the double plate Behrvelt. Where is that? Right here. I'm sorry, the 350 Behrvelt and the double plate Maltinos are quite large as well. Again, from the Mayo study, when patients had Behrvelt 350s implanted, they had a higher frequency of new onset diplopia, up to 30%, compared with patients who had smaller plate size, like Ahmed's and the smaller Behrvelt, and with an incidence of 11%. So potential causes of strabismus after large implants or small implants are the same, basically, as we've talked about already. And the numbers of implants matter also. Here's a patient that was operated on just a few days ago, who had a previously placed superior temporal implant and was now having an infranasal implant placed. This is the number of glaucoma drainage devices in the eye increase the risk both for strabismus, which you'll have to take care of, but also the risk for intractable diplopia almost no matter what we do. So to close, here are my recommendations for management of patients who have strabismus after glaucoma drainage devices. If you have to violate or are considering violating the bleb, then you certainly must consult with the glaucoma specialist because they may have some recommendations for you about how to manage their glaucoma drainage device after you've violated the bleb. It's important when we do our dissections that we try to preserve the conjunctiva as much as possible because glaucoma surface is important for drainage and for any future glaucoma procedure that they may be entertaining. It's also important that we preserve the anterior chamber, and it's not uncommon for us as we operate on these patients to see that the eye will flatten, the anterior chamber will deflate, the eye gets soft and gets much more risky to place sutures in. So it's important to maintain the anterior chamber, and you can do that one of two ways. You can either put a ligature around the tube if you have access to the tube, or you can put Helon in the anterior chamber. And it's really probably easiest just to put a paracentesis in, put a little bit of Helon right over the tube opening in the anterior chamber and be able to maintain your anterior chamber that way. So that a little forethought is very helpful when it comes to managing these patients. And you can either remove the Helon after the case is done, or you can leave it in place and it'll drain out through the tube in a matter of days. It's important, just like with the scleral buckling procedure, that you dissect the bleb and any adhesions between the implant itself and the extraocular muscles, because removal or reduction of restriction and lysis of adhesions is probably the key to success. And in my mind and experience, just freeing up these extraocular muscles is rarely sufficient. So free up the restrictions, but do your regular strabismus surgery also. So thank you very much for your attention. These are very challenging patients, very risky patients to manage, but also very thankful patients if you can successfully take care of their issues. And one final point, and I think Faruk talked about this, manage expectations. These patients have to understand that they have a difficult problem to manage and that you're going to do the very best you can to give them a good outcome. And most of the time you can, but not always. So thank you for your attention.
Thank you, Steve. Our next speaker is Dr. Ben Ticho, who is the Associate Professor of Ophthalmology at the University of Illinois in Chicago. He is at the Ticho Eye Associates in Chicago, Illinois. Ben?
Ouais. Bonjour, je suis très heureux d'être ici et de trouver des nouveaux amis ophtalmologiques. And so I'm going to talk about something that pediatric ophthalmologists deal with all the time. And contrary to some of these more rare conditions that have had prospective randomized studies, this is something that we haven't had the prospective RCT that you would expect. So here's a typical patient. We see this every day in the clinic. Patient 4 years old with a moderate hyperopia who has now developed intermittent esotropia, particularly with neurofixation. And so the question is, what glasses are we going to give her? Clearly, this is a partly or fully accommodative esotropia. And should we prescribe the full 4.5, or should we give less than that? What happens if we give 3 instead of 4.5? And you would think that in the 21st century, this topic would have been studied to death and we'd have the answers. But surprisingly, there really isn't the prospective randomized study that would answer this question and give us the guidance even for this very common clinical situation. So how do we decide to prescribe only partial versus full plus? The conventional treatment decision, of course, is, well, give the full plus. That's what you do because that's what you do. You get the best vision, you get the best results. But that's really just by consensus and what we were taught in our fellowships, except for the fellowships that said, no, give less than the full plus, and that speaks to the non-consistency of training in pediatric ophthalmology fellowship programs. Why wouldn't we give the full plus? Well, certainly anybody who's been in practice and done this knows that you don't get the compliance with wearing glasses a lot of times when you give full plus, because patients are used to accommodating and you drop them in their full plus and they won't wear their glasses. There certainly is some evidence that allowing patients to accommodate over time encourages emmetropization. So obviously most patients who walk in most kids that walk in our door are hyperopic, and we don't give them glasses because they're 1.5 or 2 diopters of hyperopia. We don't give them glasses, they're asymptomatic, and over time they become emmetropic or even myopic. So by not giving the full plus to our esotropes, perhaps we're encouraging that emmetropization. We may be also promoting fusional divergence in these patients, and that might lead us to have the greater ability to reduce or eliminate glasses in these patients over time. So the study objective that we had for this study, and this was a multi-center prospective randomized double-masked study to compare the effectiveness of partial versus full plus in new onset esotropes that had a moderate amount of hyperopia. These are our inclusion criteria, and these patients had to have at least 2.5 diopters of hyperopia in both eyes and not to have any other factors that would complicate the study of this particular question. So we did a 1-to-1 prospective randomization of full plus to 1.5 diopters less than the full plus. And remember, these are patients that had at least 2.5 diopters of hyperopia. Amblyopia treatment was treated in a standard way. And we had, in our 3 centers, 45 patients enrolled and studied them at 1, 2, and 3 months. So not a long-term study. This was just to find out, well, did we make the mistake by prescribing partial plus and then lead to future studies whether long-term results were going to be different. These graphs are pretty crowded, but basically the baseline characteristics of the two groups were pretty much the same. We had similar number of boys and girls. Most of the patients in our study were Caucasian. About half of the patients enrolled in the study in both groups had a family history of strabismus, and they were moderate hyperopes. There were usually 3 to 5 diopters of hyperopia. We included a patient questionnaire. We did Randot stereo, and we did simultaneous prism cover test to determine the tropia of these patients. How do we analyze our data? Well, the primary outcome that we were looking for was the magnitude of the residual esotropia at 2 months while wearing their spectacles. And we had a secondary outcome, which is the sort of same measurement, but having a looser criteria of what success would mean. What do I mean by that? Well, the strict criteria, we had in our 3 sites, we had some of the doctors saying, well, we don't consider this a success of esotropia treatment unless they have basically no esotropia left over. And many of us who had been in practice a little longer say, well, I consider it a success if I don't have to operate, or that they have monofixation range, and monofixation range which is going to be determined by 8 diopters or less, prism diopters or less. Again, at baseline, the baseline esotropia at distance and near was roughly the same between the two groups. Obviously, a greater deviation at near for patients reflecting their increased accommodative convergence at this testing angle. The results, the residual esotropia, again, greater at near than distance, but we had a significant reduction in esotropia as you would expect. So going back, the mean deviation at distance pre-treatment was around 18 to 20 prism diopters, and post-treatment went down to about 5 prism diopters. Similarly, at near, the preoperative deviation was about 27, and after treatment went down to about 8 to 10. So if you define success loosely versus strictly, obviously, a strict definition, we had fewer successes than the loose definition, but most patients responded pretty well, and there was no real big difference in success in either group between the partially and fully treated patients. The compliance with spectacle wear was assessed by the parental questionnaire, and basically most patients were pretty good about wearing their glasses, whether they were in full or partial plus, but not always, and some patients were noted to look over the glasses sometimes or a lot. So in conclusion, we found that patients that had moderate hyperopia treated for the first time with glasses with either full or partial correction had roughly similar rates of success, whether you considered success strictly no esotropia left over or a low amount. And there was no sufficient evidence statistically to suggest that partial plus was inferior to full plus. This study was designed mainly to show the lack of inferiority, which is just to answer the question, is it crazy, is it wrong to give partial plus? It was designed to be a stimulus to a future larger study. We only had about 45 patients in our study, and this is to stimulate a bigger study to answer a bunch of questions. We need a larger sample size to determine whether or not partial plus is appropriate for these patients. There are a lot of questions that this study brings up, and there are questions that we all think about every day. What about ACA ratio? If you calculate either strictly or in your head, oh, this patient has a large ACA defined by heterofourier method or whatever, are those patients less likely to respond to partial plus because they have a high ACA and you're not giving them bifocals, you're not even giving them their full plus? On the other hand, do you get better compliance over time or less asthenopic symptoms when you give, or more asthenopic symptoms when you give partial plus? We didn't have the statistical power to determine whether it was the same to treat a +3 patient versus a +6 patient. Both groups responded pretty much equally between the two groups, but should the +6 patients do better with partial plus because they're starting out with such a high degree of refractive error in the first place? is there a difference in amblyopia results in the two groups? We don't know this either in our study or in previous studies. What happens to non-responders? What we are hoping for is in a larger study, you would randomize between full and partial plus, and then any of the partial plus patients that didn't respond adequately, you'd then switch them to their full plus. This is a very common scenario that we deal with every day in clinic. Say, we're going to give you your partial plus, come back in 4 to 6 weeks, and if you're not corrected adequately well, then we're going to switch you to your full plus. And is that an okay strategy? Because it says, well, some patients will respond well to the partial plus, and if we don't, maybe we can rescue you anyhow and give them the full plus. So we need to find out what are the entry factors that will help predict success in either group. And we need to find out also if the patients that didn't respond in either group, both a full and partial plus, is that because you need to do atropine refractions? I don't know how many of the audience use atropine refractions primarily or secondarily in their non-responders to accommodative esotropes. But clearly, some of the patients that come back with residual esotropia, it's because you didn't adequately cycloplege them in the first place. So I want to acknowledge this is my orthoptist who did most of the grunt work for this study, and my associates over in Ohio and in California. Thanks very much.
Thank you, Dr. Ticho. And now, last but not least, Dr. Patrick Droste from Grand Rapids, Michigan. Patrick is clinical professor of ophthalmology and surgery at Michigan State University, and he is a senior ophthalmologist at Helen DeVos Children's Hospital. Dr. Droste.
Thank you very much, Mohamad, and I would like to thank John DeFarber, SOE, and APOS for the opportunity to give this presentation today. I have no financial interest. I am a member of PDIG, and all the patients in this series have given their permission to use their pictures and photographs. Third and sixth cranial nerve palsies have always been a challenge to strabismologists, particularly when the paralysis is complete. We're all familiar with the NAP procedures, the Jensens, the Hummelshines, full tendon transfers, and so on. Dr. Bob Goldberg, who's an oculoplastic surgeon at UCLA, and Art Rosenbaum, who's a member of our society, presented, what I feel, the first really good publication of using autogenous periosteal flaps to tether the globe in position for severe cranial neuropathy. They used apically based periosteal flaps, which if you read the paper, I don't know how anybody can do that surgery because the flaps are not easy to create. Most common sites were medial and lateral orbital walls. This is a patient, a 15-year-old, posterior fossa medulloblastoma, 4 years of age, was surgically removed in 2006. She received triple dose chemotherapy, and there was planned to do a stem cell transplant, so she donated her cells prior to therapy, and after therapy, she had a transplant. She continued with subtotal 6th and 7th. She also had her neoplastic problems complicated with a stroke. She had a full tendon transfer procedure on her right direction in July. Then I went back and did a maximal recession of the medial rectus in 2009, and this is what we're left with. So complete left nerve, status post left vertical transposition, LMR recession with residual left distal deviation. Now, the approach we use is plication of the lateral rectus muscle to the lateral canthus. We resect the lateral rectus muscle, and realizing now this is the fourth muscle on her eye, but we did it completely. And then we develop an external flap of periosteum off the lateral orbital rim and use a 5-0 double arm Ursuline suture. And this is, you can see the incision here of the skin. Periosteal flap is created in the lateral canthus. And here's the flap itself. We have two double-armed, one double-arm 5-0 Ursuline suture passed through the flap. And then we bring it forward through a tunnel in the conjunctiva. and tie it to the muscle insertion. Now, the surgical tip here is place Marceline suture in such a way that the knots are buried underneath the muscle. Don't do a simple interruptive so the knot's on top, because it can extrude. So bury the muscle to prevent delayed healing of the conjunctiva. This is the closure of the skin incision. This is a righted skin incision created by the oculoplastic surgeon using 6-0 Proline. And I created her 20 degrees in abduction at the end of the surgery. That was the plan of the strength of the plication, to put her in abduction, which she's never been. And this is what she she's looking to the right here, but she's really quite straight. The postneoplastic right third nerve, 32-year-old female, painful trigeminal nerve roots. She had a thalamic tractotomy, and this is what she had, a complete third nerve palsy, internal external thalmoplegia. You see her pupils blown here, eyes in abduction completely. And what we first performed was a disinsertion of the lateral rectus muscle and attachment to the right lateral orbital wall. And then we approached the medial. We use a transcaruncular approach, malleable retractors, inverted U, vertical flap, as opposed to what was in Dr. Rosenbaum's article. And a 5-0 Marceline suture threaded through a 1/2. This is probably the key part of the presentation. 1/2 round free needle sutured to the rectangular flap and then passed through the conjunctival tunnel to the muscle insertion. This is the round free needle. It has an eyelet. You put the 5-0 Marceline suture right onto it. And then we go through transcaruncular approach, medial orbitotomy. We don't go through the skin. And we get right down and do a periosteal U-shaped flap, tying it to the insertion. And we bring it up through the medial rectus muscle. And then we insert it here and pull the muscle over. This is what she looked like at the end of the procedure. This is what she looked like a week or so later. And then we still had problems with the droopy lid, so she had a frontalis sling, and that was the outcome. Last case, 55-year-old, 28-year history of multiple sclerosis, 90-plus prism diopter, exotropia. He had bilateral INOs and had constant double vision. Some people refer to this as a albino syndrome. In his case, we took the lateral muscle, exposed it, removed it from the globe, double-arm 6-0 Vicro suture, similar to the previous case. Then we took malleable retractors, used exposed periosteum of the lateral wall, and tied the sutures. Then we used then we went to the medial side. This is the lateral wall, exposing the lateral, exposure of the right orbital wall for suture placement. And now the eye's been released, complete of the plication of the right lateral rectus, preparing to approach the right medial rectus. Here we identify the medial rectus. We use the same transcoluncular approach. We have the Marceline on a round needle, put it in through here, bring it back up and tie it here. You see the needle, you can't see the Marceline suture here. Then we close it up. And then we did it really quickly on the last. I just wanted to do this, because here's the transconjunctival tunnel, which wasn't really clearly shown on the previous photographs. But this is key. It's the first thing we do after we identify the rectus. And the Marceline is attached to the tendon of the left medial rectus muscle here. Here's what it looked like at the end. This is the way he looked at the end of the procedure. We've done 5 cases. I've only presented 3. 6th, 3rd, 1 was only 2 years old, complete right third. But you can see the degrees of strabismus that they had prior. You can see most of them ended up within 10 prism diopters. And the third required frontalis sling operations. So what's the summary? Tendon plication reduces the risk of anterior segment ischemia, may be a preferred alternative to conventional transposition surgery in certain cases. Thank you very much.
Thank you very much for that great talk. May I ask the presenters to be here? We have microphones on the aisles. If any one of you have questions, we have around 15 minutes. Again, on behalf of APOS, I thank you for attending. I thank Dr. DeFaber and the SOE for the invitation, and invite you to the APOS meeting March of 2020 in Austin, Texas. Dr. Seyhan Ozurk is in the audience. Do you have any comments about Dr. Nash's comment about your paper? Dr. DeFaber, do you want to go ahead? Okay, Seyhan.
Thank you. I think for the paper that was written with our group, our considered surgery in combination with superior rectus recession was not inferior oblique recession, but inferior oblique disinsertion. I think it makes a difference because any type of recession includes some kind of anterior positioning effect, and when it is combined with superior rectus recession, the overcorrection rate is high. And in our patient group, in 3 overcorrections, we have obtained good results with ipsilateral inferior rectus toxin injection. I don't want to talk a lot about this because we are going to speak on this topic in this afternoon session. The thing that I would like to mention is that while we consider about the choice of the second muscle surgery, the other important point is the forced action test results. The superior oblique tendon laxity, the superior rectus contracture, and also the way of weakening the inferior rectus muscle is also, I think, something to be considered. So they are not uniform group of patients in the previous reports. I don't know if you share this.
Yeah, absolutely. I think forced actions, I mean, I strongly believe that should be done for every patient, and so when you head into surgery, you know, my personal practice is always, you know, there's a plan A, plan B, you know, dependent on forced actions, and again, I think the messy thing with these studies, these case series, which have these patients have so many variables that can affect their outcomes and surgical techniques, especially when you have multiple surgeons doing different things. So that's where I think that either something, you know, very specific like your guys' study, or big data that can buffer out some of that noise would be really helpful. Yeah.
Yeah, the other point that I would like to, is a short comment, is after seeing these overcorrections after superior rectus recessions, we now skip to inject botulinum toxin into the ipsilateral superior rectus muscle, and we reported preliminary results, and the full results are going to be published soon, and I'll show some case demonstrations this afternoon. Thank you.
Thank you.
Thank you very much. Dr.
I can-
DeFaber? Dr. Örge, go ahead.
I
Go
did-
ahead.
Man,
Go ahead.
How can I go ahead in front of the
I'm
Mr.
asking
President?
you to go ahead.
Thank you, sir. Then I will. Actually, I just wanted to comment on patient expectations in many of these cases, and I think we all had these overcorrections, undercorrections, what do you do, and similar to giving glasses. 2 of the speakers mentioned, actually maybe all of us mentioned in a way that patient expectation and having the patient in the discussion is, I think, is a key point. In particularly on a 40, 50-year-old fourth nerve palsy congenital, I actually give them all the options. I tell them that I can do one muscle and see what happens and we can go forward, versus we can do the second muscle, even a third muscle, but really making them understand and being a part of that decision making, I think, is a key factor. Whatever the outcome is, they tend to at least remember that you had the discussion with them. And I think that really, because they are miserable patients, they don't know what to do with this overcorrection. All their life they have been actually using all their fusional amplitudes to bring the paralytic side into alignment, and all of a sudden when you throw them off, they just don't know what to do. Again, I just want to underline that patient aspect.
Thank you, Faruk, and thank you for mentioning the fusional amplitudes, which are really very helpful in patients with congenital. Dr. DeFaber, with no interruptions.
Oh, okay, thank you. Faruk's talk and Stephen Christian's talk were about iatrogenic strabismus. And I think a message should go out to those subspecialties which deliver us these patients. And of course, I realize that if you don't do a buccal, then you won't even have any diplopia because your vision will go down. But in my clinic, I try to show these cases and said, hey, listen, this is a complication of your treatment. And especially because the shunting devices, the Barfelds and the Ahmed valves, in the beginning they were not realizing what this is doing to a very, like the orbit, it's like a garage with your car in, and then you try to put a lot of more stuff in that garage and then causing motility problems. What is the opinion of the APOS about that? Are you doing explanation to those subspecialties, or is this so rare that they don't take the utmost care in placing tubes or encircling bands and plums?
Stephen, you are the outgoing program director of APOS, and you are chairman of the Department of Ophthalmology. So what do you tell your colleagues?
That doesn't help me a bit. The good news on the scleral buckling side is that the frequency of scleral buckles is going way down. Retina surgeons who used to do 3 or 4 buckles a week are now doing 1 to 2 a year. That may be a good thing because fewer patients are being placed at risk for strabismus, but for the unfortunate patient who has the inexperienced retina surgeon doing his first or second scleral buckle that year, sometimes they run into more complications. Your issue that you were commenting on, Jan, was actually how do we communicate with our other subspecialty organizations? And unfortunately, that communication doesn't happen very well except through the literature. And in the departments when you have patients that you share with your colleagues. So I think it's important that we go to meetings like this, talk about it, make sure that the word is out, and I think that the story is certainly becoming clearer that the larger glaucoma drainage devices are a much more significant risk. So I think we're going to see fewer of those happening. But to be honest with you, interspecialty communication is not very good and probably needs to get a lot better.
And many institutions actually do have the what we call the MMB. We don't have the MNM, the mortality, but the morbidity and blindness. And we discuss these cases quite a bit if it comes up. I think I 100% agree that this has to be disseminated. But on the other hand, I've seen excellent surgeons and just the complications that occur. People do heal in a different fashion. And I sometimes generate my own patients because I do pediatric glaucoma quite a bit, and I've done everything exactly the same with one eye, and all of a sudden the other eye has this type of complication. It does happen, and no matter what the communication is going to be, I think we need to be aware that this can happen. But you're absolutely right. That communication, if you're seeing a source that a particular surgeon or group is causing this, I think that communication has to be there for the patients. Thank you for the comment.
And we did with the ENT surgeons. I mean, thank you. Yeah.
Yep.
Sir.
A small question, Dr. Loba from Poland. I would like to ask actually Dr. Örge, but it's a question to the whole panel. Do you have any experience with patients, especially like you've shown after ENT surgeons going into the orbit and having very severe fat adhesions within the Tendon's capsule, so actually on our side of the muscles. And actually the cases, in such cases you have a situation that you disinsert the muscle and you still cannot get free reductions. Nevertheless, the muscle is disinserted. Of course, if you clear the adhesions, you'll improve the passive ductions, but if you leave it like this, you'll have the adhesions after several weeks again. So do you have any experience in putting materials like amniotic membrane or using any kind of anti-adhesive drugs to cure those patients? Do you have any experience?
I'll give you my point of view from the end of so many cases. I mean, thank God I don't have hundreds of these cases, but In these cases, because of the mucosa of the sinuses, as well as the muscle itself and the bone, and this is a very different soup that you have, the mesh, and the exudation is so profound, it actually involves anything and everything around it. If you're lucky, it's a quick in and out, and then actually I have seen one case that was repaired, meaning not me, but it was presented somewhere else, and I congratulate them, but I think it was a partial kind of a munch of the muscle. It was a very different animal, what I suggested. I can tell you it's almost impossible to go back and remove the scar tissue. For different things, I have used amniotic membranes, I've used viscoelastics, I've used steroid injections, anything that you can think of, and layered them all. In some cases, actually, I've done every one of them multiple times, and it just still comes back. The first thing is to really prevent the adhesion. So that's why if you're going to do something, and if you know this was actually a big area that it was affected, and if the imaging is of help, if they can get it right away, you can actually see how it's involved, I would really suggest these traction sutures. I think that, but you have to do it early on before the scar tissue sets in. If you do this a month after, it won't do anything. As you said, even if you kill the lateral rectus or transpose these muscles, I had cases that just almost like did nothing at all.
How long do you leave the traction sutures in?
That's actually what
So
we do as well. Yeah, mostly also in orbital fractures. This is the case when the maxillofacial surgeons, they sometimes go through the tenons inadvertently, and that's the same situation, and the traction sutures, they really work sometimes, yes.
So the question was, how long do you keep the traction sutures? The answer is you try to keep it as long as you can. It tends to cheese wire. I've heard this from Steve Kraft and many other people, and in my case actually cheese wired, and I wanted to keep it there for a week or 10 days. It's extremely uncomfortable for the patient. They have very severe pain, but it cheese wires.
Thank you. One more comment or question from Dr. Rosario Gomez.
Yes, is in the way of those traction sutures, maybe you could combine it with Botox, because I mean, the traction suture, you don't support it so many days. So if you can get maybe 1 day of traction suture and then immediately use a Botox, if you have to take out the traction suture, you still have the Botox there, or only the Botox.
Thank you for mentioning that, and I forgot to mention that actually that's exactly what we did with the case. You have to do the Botox at the same time, and or just maximal recession, whatever the du jour is, or a combination of these things. Fantastic comment, thank you.
Thank you all for attending. Thank you for the comment and presentations, and this concludes the session on time.